Hello everyone, my name is Bailey and this video will be over rotator cuff tendonitis and tears. The first slide is over the anatomy of the shoulder. The anterior view, you have the subscapularis, the humerus, the clavicle, supraspinatus tendon, subscapularis tendon, and the capsular ligament that you can see. Posterior view is infraspinatus, supraspinatus, the teres minor, humerus, posterior tendon junctions, and the scapula. So the pathology for rotator cuff tendonitis, it is an irritation of the tendons either from excessive pressure on the acromion or less commonly from intrinsic tendon pathology. The pathology for rotator cuff tears is when one or more of the rotator cuff tendons tears or detaches from the humerus. These tears can vary in size and can be acute or chronic. They usually occur near the insertion of the greater tuberosity and most commonly involve the supraspinatus tendon. And so in this picture you can see a partial tear of the rotator cuff as the supraspinatus tendon has torn right through here, and this is a partial tear. A full tear would be when it rips all the way through the tendons, and it's a complete tear, obviously, right through here. The mechanism of injury for tendonitis, repetitive overhead activities, mainly caused by overuse of the shoulder. So yeah, basically baseball pitchers, anyone pretty much who's playing baseball, and tennis and softball. And if you're a quarterback for football, you can get tendonitis in your rotator cuff from if you are passing a lot. Mechanism of injury for the rotator cuff tears. Primary mechanisms are acute trauma of high velocity rotation, repetitive overhead activities, a single traumatic event such as falling on outstretched hands, otherwise known as fooshing, aging and just common usage, like once you get older, you're more likely to tear your rotator cuff, even if you have a past history of a lot of overhead activities. Developing degenerative tears caused by compression action of the humeral head hitting the acromion. So as you can see in this picture, if he lands stiff down, his hands real hard down into the ground here, his humerus will slide all the way up into his acromion up in here, and it could possibly tear his rotator cuff. Also, if his hand comes all the way up above his head, that is a good possibility for a rotator cuff tear. Alrighty, some signs and symptoms are pain, weakness with lifting and or lowering the arm, atrophy of the shoulder muscles, crepitus in the shoulder, point tenderness, and pain while lying on injured shoulder. So like if you're asleep also and you roll onto your shoulder and it wakes you up in the middle of the night, that is a good possibility that you have torn your rotator cuff. For rotator cuff tendonitis, pain and swelling in the front of the shoulder and side of the arm, a stiffness in your shoulder, pain when raising and lowering the arm, loss of mobility and strength in affected arm. So it can be very easy to mix up tendonitis and a rotator cuff tear because they can have similar signs and symptoms. So some special tests to test if you have a rotator cuff tear or not. The drop arm test, the Jobe empty can test, external rotation lag sign, or Gerber Lift-off test. So the drop arm test tests the strength of the supraspinatus and infraspinatus muscles, has a sensitivity of 73% and a specificity of 77%. And we will watch a video on how to perform this test right after this ad.
In this video, I'm going to show you how to do the drop arm sign to diagnose full thickness rotator. The drop arm sign has a sensitivity of 73% and a specificity of 77% in the diagnosis of full thickness tears of the supra and infraspinatus tendons. The post-test probability of a full thickness tear is therefore only moderately altered, which is why we assign this test a moderate clinical value. To perform the drop arm sign, have your patient in standing or sitting position and bring the affected arm into 90 degrees of abduction and external rotation passively. Then tell your patient to hold this position and release your supporting hand. This test is positive for full thickness tears of the supra and infraspinatus if your patient is unable to slowly control the downward movement. Thus the name drop arm sign.
Alrighty. That shows you how to perform a drop arm test. That tests for supraspinatus and infraspinatus muscle strength or weakness. The Jobe empty can test tests the strength of your supraspinatus specifically, sensitivity of 74% and specificity of 30%.
In this video, I'm going to demonstrate the Jobe or empty can test and a specificity of 30%. To conduct the Jobe test, have your patient standing, elevate both arms to 90 degrees of forward flexion in the scapular plane, which is referred to as scaption, then fully internal rotate the arms and have the thumbs point towards the floor. And then you're going to apply downward pressure to prevent further elevation. A positive test is the reproduction of pain on the injured side. If you're able to elicit pain during...
So yeah, that test tests the strength of your supraspinatus muscle. The external rotation lag sign tests for infraspinatus and teres minor weakness. Has a sensitivity of 97% and a specificity of 93%.
Writing's not that easy, but Grammarly can help.
I
This
love
sentence
ads.
is grammatically...
In this video, I'm going to talk about the lateral rotation lag and a specificity of 93% for full thickness tears of the infraspinatus and a sensitivity of 100% and a specificity of 93% for full thickness tears of the teres minor. To perform the test, bring your patient's shoulder into 90 degrees of abduction and maximal external rotation and ask your patient to hold this position. If your patient is able to hold this position, this indicates a negative test. For a positive test, however, your patient would not be able to hold this position and his arm would spring back anteriorly, indicating that the teres minor and the infraspinatus are weak or painful. Okay, this was our video on the lag sign.
Alrighty, so there you go. You have external rotation lag sign to test infraspinatus and teres minor weakness. Next is the Gerber Lift-off test. Test for subscapularis weakness. Has a sensitivity of 40 and a specificity of 79.
This is going to be a video on the lift-off sign to assess for weakness or lesion. To conduct the test, have your patient standing with the dorsum of his hand against the mid-lumbar spine. Then ask your patient to lift off the hand from the back and watch for abnormal motion of the scapula, which could indicate scapular instability. If the patient is unable to do so, this indicates a lesion of the subscapularis. If the patient is able to lift off the hand from his back, you can give resistance to test for the muscle strength. Alright, this was our video on the lift-off sign.
So there was a video to show you how to perform a Gerber Lift-off test, the test that's testing subscapularis weakness and strength. Predisposing factors for rotator cuff tears and tendonitis. Anyone that participates in any overhead throwing, such as baseball, softball, football, or tennis. Anyone who works in any type of construction and is repetitively moving their arm in an overhead motion. Any past family history and age can be a factor. Some management and treatment of the rotator cuff tears and tendonitis, possible surgery, some NSAIDs, rest, ice or heat. Injections have also been known to help with rotator cuff tears and tendonitis, and physical therapy. Any type of referral or immobilization for rotator cuff tears and tendonitis, you can refer them to a doctor, and a doctor will either refer you to a surgeon, MRI or X-ray, depending on if it's a tear or not, or if it's just tendonitis. If it's tendonitis, you will probably go to the physical therapist to do some rehabilitation on your shoulder to help stop the inflammation. Some prevention for rotator cuff tears and tendonitis, proper strengthening and stretching of rotator cuff muscles, using the proper techniques necessary for overhead throwing. Not all tears can be prevented though in the end. Some just happen just out of nowhere. There are no Mulligan techniques to help treat rotator cuff tears or tendonitis. Some differential diagnosis, frozen shoulder, snapping of the scapula, glenohumeral arthritis, acromioclavicular arthritis, subscapular neuropathy, cervical radiculopathy, and cervical spondylosis. So here's my PICOT analysis. If you guys want to read it, you guys can pause the video, and so I will let this sit here for a good 10 to 15 seconds, so you can pause it and read over it if you really want to. Okay, so my population was 29 massive rotator cuff tears involving complete detachment of at least 2 tendons. The eye was repaired operatively with use of new laboratory tested techniques in a prospective study. The comparison was to determine whether a new method of repair of rotator cuff tendons can yield a lower retear rate and a better clinical outcome than previously reported methods. Also, to assess the muscular changes following repair of massive tears of the musculotendinous units, to correlate findings on magnetic resonance imaging with the clinical results. The outcome, the method of repair of massive rotator cuff tears that was used in a study yielded a comparatively low retear rate and a good to excellent clinical results. However, the repair did not result in substantial reversal of muscular atrophy and fatty degeneration. Retears occurred more often in patients who had a shorter interval between the onset of the symptoms and the operation. Patients who had a retear had improvement of the shoulder compared with the preoperative state, but they had less improvement than did those who had a successful repair. And the time was at least 2 years, average of 37 months. The range was 24 to 61 months. And there are all my sites. And thank y'all for watching my presentation. I hope you liked it. If you liked it, leave a like down on the video and hit that subscribe button to see more injury analysis PowerPoints.